Next, we have with us Dr. Ashraf Habib from the United States of America. He is professor with tenure in the Department of Anesthesiology, Duke University Medical Center, Durham, North Carolina, United States. He is also professor in obstetrics and gynecology. Today, we have Dr. Ashraf Habib speaking to us on a very pertinent and important topic of great clinical relevance when we deal with pregnant patients coming for C-section. Presenting to you, Dr. Ashraf Habib.
Hello, everyone. My name is Ashraf Habib, and I'm an obstetric anesthesiologist from Duke University in North Carolina. First, I would like to thank the organizing committee for inviting me to be part of this virtual meeting, and hopefully we'll have opportunities to meet in person in the future. My talk today is about enhanced recovery after cesarean delivery. Enhanced recovery is a concept that combines various evidence-based aspects of perioperative care to accelerate patients' recovery. Initial studies about enhanced recovery were in patients undergoing colorectal surgery. And these studies showed enhanced recovery and improved outcomes in various aspects of patients' recovery, including a significant reduction in the duration of hospital stay. Since then, there have been increasing adoption of enhanced recovery protocols in various types of surgery. And recently, there have been increasing interest and adoption of enhanced recovery in C-section patients. The general principles are the same, but obviously, since the obstetric population is a unique patient population, the specific details of those protocols will be different. So over the next 25 minutes or so, we're going to discuss various aspects of enhanced recovery after cesarean delivery protocols. Here are my disclosures for research support and advisory board work I have done. So our objectives today is first to talk about the quality of recovery indicators following cesarean delivery. Then I'm going to give you a broad overview of the essential elements of an enhanced recovery after cesarean delivery or an ERAC protocol. Then we're going to speak into a little bit more details about some of the intraoperative elements of the ERAC protocol. And finally, we're going to talk briefly about the impact of ERAC implementation. So how to measure the quality of recovery following cesarean delivery? And how do we optimize the outcome then? So recently, a quality of recovery following cesarean delivery score has been published, and it includes 11 elements. 3 of these elements deal with pain. So obviously we can address that by adopting a multimodal opioid-sparing strategy. 1 element relates to nausea and vomiting, and we can address that by attention to intraoperative and postoperative nausea and vomiting, as well as using opioid-sparing strategies for postoperative analgesia. The next element relates to dizziness, and we can address that by prevention of spinal-induced hypotension and by using non-sedating agents for analgesia and for management of side effects. The next item is shivering, and we can prevent shivering by preventing intraoperative hypothermia. Next 2 items relate to the ability to breastfeed the baby and to hold the baby. And we can help that by facilitating early skin-to-skin contact, by providing adequate postoperative analgesia, and providing breastfeeding support for our patients. And finally, the last 3 elements deal with the ability to mobilize independently, to look after personal hygiene, and to feel in control. And we can facilitate this by removing barriers to early mobilization, such as urinary catheters and IVs, providing adequate control of postoperative pain and postoperative nausea and vomiting, and providing adequate patient education so that the patients know what to expect during and following their cesarean delivery. So now let's talk about the essential elements of the IRAC pathway. And since similar to other enhanced recovery after surgery protocols, this is divided into a preoperative, intraoperative, and postoperative component. The preoperative component includes patient education. Patient education is very important. We need to let patients know what to expect during and after the cesarean delivery. They need to know that we're going to mobilize them early. They need to know what post-operative analgesic regimens we are going to use. They need to have an idea of the length of hospital stay and what criteria they need to fulfill in order to be discharged from the hospital. And we can actually give the patients some milestones that they need to meet so that they can be engaged in the recovery process. The antepartum period is also an opportunity to optimize comorbidities such as diabetes and hypertension, and to optimize hemoglobin. We have an anemia clinic at our institution, and obstetric patients have certain criteria to be referred to this clinic in order to optimize hemoglobin and resolve any anemia. NPO should be according to guidelines, 6 to 8 hours for solids and 2 hours for liquids. And a preoperative carbohydrate drink is included in many of the enhanced recovery protocols. It has been shown to reduce thirst, reduce hunger and anxiety, decrease insulin resistance, and keeps the patients well hydrated. And we also need to establish and review the ERAS protocols and goals with the patients preoperatively. The intraoperative part is the part that is mostly under the control of the anesthesiologist. So the anesthetic technique is, the recommended technique is the neuraxial anesthesia using long-acting neuraxial opioids. We prevent infection by administration of antibiotics and by skin and vaginal preparation. We pay attention to the prevention of hypothermia, prevention of hypotension, nausea and vomiting prophylaxis, and also to other elements related to delayed cord clamping, which is recommended by ECOG currently, and facilitating early skin-to-skin contact in the operating room. Finally, the elements of post-operative part relate to early oral intake and early mobilization, and removing barriers to early mobilization. Remove the urinary catheter early, for instance. In practice, we remove the urinary catheter within 6 hours after surgery. We need to implement a multimodal opioid-sparing analgesic regimen. Adequate post-operative analgesia is the cornerstone of all enhanced recovery after surgery protocols. I'm going to spend some time talking about that in a few minutes. Other elements of post-operative care include adequate thromboprophylaxis, lactation support, and coordination with the neonatal team visit so that patients are not delayed from discharge from the hospital because of issues relating to their baby or to breastfeeding issues. And finally, it's very important to continuously audit compliance with the various aspects of the IRAC protocol, as well as keeping track of your outcomes so that you can continuously fine-tune your protocol and improve your outcomes. Now let's talk into a little bit more details about some of the intraoperative elements of the IRAC protocol. And we're going to talk about prevention of hypotension, prevention of hypothermia, nausea and vomiting prophylaxis, and multimodal analgesia. So let's start with hypotension. And as we all know, hypotension occurs commonly following spinal anesthesia. Up to 78 to 80% of women will develop hypotension without prophylaxis. And fluids have traditionally been used for the management of hypotension. But we now know that fluid loading strategies have limited efficacy. Whether you give a colloid or a crystalloid, whether you give it as a preload or a co-load, at best, you reduce the risk of hypotension from 70 to 80% to about 60%. So fluids on their own have limited efficacy. And the mainstay for the management of hypotension are vasopressors, because the main pathophysiology is vasodilatation. And we have now plenty of data showing that phenylephrine is superior to ephedrine because of it's associated with improved neonatal acid-base status, less neonatal acidosis, and also associated with better maternal comfort. The instance of intraoperative nausea and vomiting is significantly less when you use phenylephrine compared to using ephedrine. What is the optimal way to give phenylephrine? Giving it the prophylactic infusion is a much better way than giving boluses in response to hypotension. There are a number of studies that showed this. This is one of them, showing that the variable rate of phenylephrine infusion is associated with less hypotension and less intraoperative nausea, less physician interventions to manage hypotension compared to treating established hypotension with phenylephrine boluses. So where should we keep the blood pressure? This was a very elegant study that looked at 3 regimens using a prophylactic phenylephrine infusion. One regimen aimed to keep the blood pressure at 80% of baseline. The other one was kept the blood pressure at 90% of baseline. And the third maintained the blood pressure at 100% of baseline. And as you can see here, the incidence of hypotension was 40% when the blood pressure dropped by 20%, 16% with a 10% drop in blood pressure, and only 4% when the blood pressure was kept at baseline. This should be our goal, to keep the blood pressure at baseline. Recently, there have been interest in using norepinephrine for hemodynamic management in patients undergoing cesarean delivery. As you know, phenylephrine is a pure alpha agonist, whereas norepinephrine has some beta agonistic effect. And in this study, you can see the comparison between a phenylephrine and a norepinephrine prophylactic infusion. You can see that blood pressure control was the same. However, because of the beta agonistic effect of norepinephrine, heart rate was higher in the norepinephrine group, which led to a higher cardiac output. Stroke volume was the same, but systemic vascular resistance was lower in women who received norepinephrine. Whereas currently we don't have data to suggest better outcomes with norepinephrine, but this information of about higher cardiac output, low SVR might suggest better perfusion of peripheral tissues, better perfusion of the placenta. So there theoretically could be benefits, but further studies are needed to demonstrate that. But for the time being, phenylephrine is considered the vasopressor of choice. Next, let's talk about uterotonics, an important element affecting the incidence of intraoperative hypotension. We know that oxytocin is the first line agent, uterotonic agent, and historically we have been giving too much oxytocin, much more than what is needed. This was a very elegant study looking at the ED90 of oxytocin infusion in non-laboring patients and in laboring patients. And you can see that the ED90 in non-laboring patient was 16 international units per hour. And in laboring patients who are being exposed to oxytocin, it's more than double that. It's 44 units per hour. If you look at the ED90 of an oxytocin bolus, it's pretty much the same information. In elective cesarean delivery, the ED90 is 0.35, and intrapartum cesarean delivery, the ED90 is about 3. So still much lower than the doses of oxytocin that we gave in the past. Historically, 10 units of oxytocin were given, and then they were reduced to 5 units of oxytocin. But we need much less than that for maintaining uterine tone, initiating uterine tone for cesarean delivery patients. And in our practice, we're seeing an increasing prevalence of obesity. I don't know about India, but this is a significant problem in our practice. And this was a very recent study showing that the ED90 of the oxytocin bolus is higher in obese patients, 0.75, so almost double what we saw in non-obese patients. Last year, there was an international consensus statement published about the use of uterotonics and what they recommend for elective cesarean delivery to give 1 unit of oxytocin bolus, followed by 2.5 to 7.5 units per hour. And if after 2 minutes the uterine tone is not adequate, give a further 3 units of oxytocin. For intrapartum cesarean delivery, they recommend the higher dose of 3 units, followed by 2.5 to 7.5 units per hour. Now let's talk about hypothermia. And in the general surgical population, there have been a lot of attention paid to hypothermia, and its consequences have been well delineated. It leads to an increase in blood loss, increased risk of wound infection, of complications such as myocardial ischemia. It affects the pharmacokinetics of drugs, and it leads to prolonged duration of hospital stay, prolonged recovery, room stay, and therefore it leads to increased cost. However, hypothermia has not gained a lot of attention in obstetric patients, despite the fact that it occurs very commonly. This is a study that reported a 91% instance of hypothermia in patients who did not receive any active warming. And even in those who received 2 modalities for warming, the risk of hypothermia was 64%. And these were women who were undergoing cesarean delivery under spinal anesthesia. In another study from South Africa, the patient ingested a temperature sensor, and the authors were able to describe with high resolution the degree of hypothermic insult associated with spinal anesthesia in a group of patients who were not routinely warmed. You can see here that there was a drop in temperature by more than 1 degree centigrade, and it occurred, maximum drop was about an hour following the performance of the spinal anesthesia. Temperature continued to drop even after leaving the operating room, and in some patients, the temperature did not return to baseline even after the 8 hours duration of the study. So hypothermia occurs commonly, and its duration and magnitude are very much underappreciated. So what can we do to prevent hypothermia? Institution of active warming is effective. This was a meta-analysis our group did a few years ago, and as you can see here, active warming resulted in the pooled data in a reduction of hypothermia by 34%, reduction in shivering by 42%, increased thermal comfort, resulted in higher temperature at the end of surgery, and even resulted in higher umbilical artery pH in the neonate. And in addition to active warming, we need to pay attention to the ambient temperature in the operating room. This was a study that looked at 2 temperatures for the operating room, 23 degrees centigrade and 20 degrees centigrade. And you can see here that the instance of hypothermia, maternal hypothermia, and neonatal hypothermia were significantly lower in the group of ambient temperature of 23 compared to that of 20 degrees. However, one thing we need to pay attention to that some of the surgeons in this study actually felt uncomfortable with the higher temperature. Therefore, you need to work with your obstetric team to agree on a temperature that will be warm for your patients and at the same time doesn't cause discomfort for the operating team. Next, we'll talk about nausea and vomiting prophylaxis, and we're going to talk first about intraoperative nausea and vomiting. There are anesthetic factors and there are surgical factors that we need to pay attention to. We'll start by anesthetic factors. So we talked already about the prevention of hypotension, using a prophylactic phenylephrine infusion and keeping the blood pressure at baseline. Adding lipophilic opioid such as fentanyl improves the quality of your block and significantly reduces the risk of intraoperative nausea and vomiting by 59% in this recent meta-analysis, because it reduces any intraoperative pain and reduces the need for any opioids that could result in nausea and vomiting. Giving antiemetic prophylaxis with a combination of antiemetics is effective. A few years ago, we did this study where we looked at the use of metoclopramide with ondansetron in patients who were receiving a prophylactic phenylephrine infusion, and we found that the incidence of intraoperative nausea and vomiting was reduced by more than half. So we adopted this in our practice. There are also important surgical factors that contribute to intraoperative nausea and vomiting, including externalization of the uterus and intra-abdominal irrigation. Externalization of the uterus significantly increases the risk of intraoperative nausea and vomiting. There are a number of studies that looked at that. This is one of them. I'm not sure about the practice of India, but it is actually a common practice in the US here. For this is something that we need to work on to avoid externalization as much as possible, to reduce patient discomfort and the risk of intraoperative nausea and vomiting. Intra-abdominal irrigation at the end of surgery has also been found to increase the risk of intraoperative nausea and vomiting, as well as post-operative nausea and vomiting and need for rescue antiemetics. And in this meta-analysis, intra-abdominal irrigation was not found to have any benefits in terms of reduction of a post-operative fever or post-operative infectious complications. For post-operative nausea and vomiting, you need to use a combination antiemetic therapy. So in our practice, in addition to metoclopramide and ondansetron that I mentioned, we also add dexamethasone to this regimen. And then you need to pay attention to the way you provide post-operative analgesia. We need to pay attention to the dose of the intrathecal morphine and use multimodal analgesic strategies. And this is what we're going to discuss now. So as you know, intrathecal morphine is now considered the gold standard for analgesia following cesarean delivery. But with intrathecal morphine, there is an analgesic ceiling and dose-related increase in side effects, meaning that there is a certain dose above which you don't get any further improvement of analgesia, but you only get an increase in side effects. This was a meta-analysis that looked at low dose of intrathecal morphine, which was defined as 50 to 100 micrograms, compared to high dose of intrathecal morphine, which were any doses above 100 to 250 micrograms. And what they found here, that there was no difference in pain scores between the two groups, but the risk of side effects, including pruritus and nausea and vomiting, were significantly higher in the high-dose intrathecal morphine group. In addition to intrathecal morphine, we need to use systemic adjuncts to optimize analgesia. And the most commonly used agents are a combination of NSAIDs and acetaminophen. And studies have shown that the combination of these two agents provide improved analgesia compared to using each agent alone. And the other thing that's important about the use of these adjuncts is that there is a synergistic effect between acetaminophen and opioids. And this resulted in a common practice of using acetaminophen opioid combination tablets for analgesia following cesarean delivery. But over the last few years, there are at least a couple of studies that showed that if you split the acetaminophen from the opioid, meaning that if you give scheduled acetaminophen and reserve the opioids for rescue, you actually improve postoperative analgesia and reduce opioid consumption compared to the practice of giving the combined acetaminophen opioid tablets as needed. The other point to highlight with regards to using NSAIDs and acetaminophen is that it's better to give them at the same time rather than to give them alternating doses every 3 hours. This was a study, recent study, that showed that giving both agents alone actually improves postoperative analgesia and reduces opioid consumption compared to alternating doses. And actually giving this in this way agrees with the IRAC principles in that you minimize disruption for the patient's sleep. Finally, initiating these agents intraoperatively is more effective than starting their administration after surgery in the recovery room. These were results from a recent study we've done where we looked at our change of practice from initiating these agents orally in the recovery area to giving them intraoperatively, and we found a significant reduction in the need for rescue opioids postoperatively with the new regimen, especially in the early postoperative period. Other systemic adjuncts, such as gabapentin and ketamine, are commonly included in enhanced recovery after surgery protocols for other surgical disciplines. But in patients undergoing cesarean delivery, gabapentin has been shown to have very marginal analgesic benefit at best, but it significantly increases the risk of sedation and severe sedation. Ketamine can be helpful, but can be associated with dizziness and dysphoria. So these two agents are not really recommended for routine use in our patients, but could be reserved in patients at high risk for severe pain, such as patients with chronic pain or patients who are on chronic opioids. Neuraxial adjuncts, the most commonly investigated is neuraxial clonidine. It's actually helpful in reducing opioid consumption and prolonging to time to the first rescue. However, it comes at the expense of an increased risk of sedation and hypotension. So again, I wouldn't use clonidine routinely, but I will reserve it to those patients at high risk for severe pain after surgery. Now let's talk about some regional techniques. And the most commonly investigated one has been the transversus abdominis plane block, or TAB block. This was a meta-analysis we did several years ago, and a few studies have been published after that, but the conclusions remain the same. In patients who do not receive intrathecal morphine, TAB blocks are very useful in optimizing postoperative analgesia. However, they do not provide as good of analgesia as intrathecal morphine. Remember, intrathecal morphine covers both somatic and visceral pain, whereas TAB blocks will only cover incisional pain. If you add the TAB block on top of intrathecal morphine, it does not provide any additional analgesic benefit. And this is because the block wears off while intrathecal morphine is still effective. However, recently, a study was published looking at the use of liposomal bupivacaine, which is a long-acting preparation of bupivacaine, works for 72 hours, so basically outlasts the duration of neuraxial morphine. And this study found that when the block is placed correctly and you adhere to a multimodal analgesic regimen, opioid consumption is reduced in the hospital through 72 hours, as well as following hospital discharge. Another truncal block is the quadratus lumborum block. It has been less investigated in C-section patients, but more and more studies are coming out, and the conclusions are pretty much the same, similar to the TAB block. They are very helpful in patients who do not receive intrathecal morphine, but do not seem to be beneficial when done in patients who have received intrathecal morphine. One aspect of the quadratus lumborum block, though, is that they have the potential to cover visceral pain, not only incisional pain. Therefore, there was an interest in comparing them with TAB blocks, and at least a couple of studies have suggested that quadratus lumborum block might provide better analgesia than TAB blocks, but studies are limited so far and more data are needed. Finally, I'm going to talk about the impact of implementation of the IRAC protocol. There are many studies that have been published, but I'm going to show you only one of them. This was a study from an integrated healthcare from California. This includes 15 hospitals that systematically implemented an Iraq protocol. And as you can see here, it covers preoperative, intraoperative, and postoperative components. And as you can see on the side here, they showed a change in early mobilization, early feeding, increase implementation of multimodal regimen, and significant reduction in opioid consumption. So to conclude, Iraq protocols involve a multidisciplinary effort and include preoperative, intraoperative, and postoperative components, and data so far has shown that they have been associated with improved quality of analgesia and improved quality of recovery. And I want to refer you to the recently published consensus statement and recommendations for enhanced recovery after cesarean delivery from the Society of Obstetric Anesthesia and Perinatology. It's a comprehensive document, and I recommend that you refer to it. Thank you so much for your attention, and I believe we might have a few minutes for questions and answers. Thank you so much.